All right, so good afternoon, everyone. Thank you for joining us for today's Well Ahead Wellness webinar on chronic disease awareness. My name is Amory Frischhertz, and I am the Diabetes Innovation Manager here at Well Ahead, Louisiana. The Louisiana Department of Health, LDH employees, contractors, affiliates, et al., have no actual or potential conflict of interest in relation to this program presentation. The content herein is intended for general guidance, not as legal advice. Laws and regulations take priority if there are any differences. Only LDH's Secretary or Surgeon General can give official statements. LDH cannot speak for other government agencies, and if you need legal advice, you should consult a lawyer. So during today's webinar, we hope that you learn ways to drive collaboration throughout the state that connects communities to tools and resources that can improve the health of our residents where they live, work, learn, play, and pray. Now I will turn it over to Dr. Glennis Gray, Deputy Assistant Secretary in the Office of the Assistant Secretary within the Office of Public Health at the Louisiana Department of Health.
Thank you, Anne Marie, and good afternoon, everyone. I want to welcome you to today's webinar on chronic disease awareness. Well Ahead is the chronic disease prevention and healthcare access arm of the Louisiana Department of Health, the Office of Public Health. And so our major vision is to reduce the burden of chronic disease and assure access to quality healthcare for all Louisiana residents. We work along all types of leaders at key organizations across the state. And so some of these are child care centers, colleges and universities, faith-based organizations, restaurants, work sites, and healthcare facilities. And so we try to create an environment where everyone can be healthy. And we believe that everyone has a role to play in connecting Louisiana communities to a healthier future. So we're committed to educating and empowering leaders, and hopefully you'll get something from this webinar that will empower you to work with other state leaders across the state with actionable steps to move Louisiana's health forward. Again, I want to welcome you to today's webinar, and I'll turn it back over to you, Anne Marie.
Thank you, Dr. Gray, for the warm welcome. So I have the pleasure of introducing today's speaker. Dr. Chantel Hebert-McGee is a champion of health justice, committed to bridging healthcare disparities and improving outcomes for underserved communities. With over 15 years of leadership in healthcare administration, public health, research, and clinical practice, she has dedicated her career to expanding equitable access to care and driving systemic change. Having grown up with firsthand experience of hardship, Dr. Hebert-McGee developed a profound commitment to serving vulnerable populations. As the first Black Chief Medical Officer for Louisiana Medicaid, she led initiatives that expanded behavioral health treatment, cancer and rare disease therapeutics, and rural healthcare access. In her role as Regional Medical Director for Greater New Orleans, she safeguarded more than 1 million residents during the COVID-19 pandemic and Hurricane Ida by leading field hospitals and vaccine distribution efforts. Now, as Capital Regional Medical Director, she continues her mission to advance health equity and strengthen medical access in the capital area parishes. Her influence extends beyond borders. She has led global health efforts to improve early cancer diagnostics across Europe, Asia, and Latin America, and played a key role in bringing 2 FDA-approved clinical devices to market. A passionate advocate, she has published extensively on cancer research and health disparities, produced an award-winning film addressing college sexual assault, and provided mini microscopy through UTS Foundation, a program that empowers at-risk youth by using microscopic examination to explore social ills. Dr. Hebert-McGee's career spans roles as a clinician, venture lead, minority health strategist, and nonprofit CEO, making her a powerful force for systemic change. Recognized for her leadership, she remains deeply rooted in community, carrying forward the legacy of 8 generations in New Orleans. A proud alumna of Clark Atlanta University, Georgetown University School of Medicine, and Harvard School of Public Health, she continues to lead with compassion, vision, and an unwavering commitment to equity. Dr. Abair McGee, the floor is yours.
Well, thank you. I didn't expect for you to read all that. I thought it was just something that you would share with the audience, and I didn't want to interrupt you while you were speaking. But thank you. And I appreciate everyone for listening to that very lengthy introduction. And I appreciate you allowing me to spend some time with you all today to discuss the role of public health and the pivotal role it played in the foundation when it comes to preventing and mitigating chronic diseases. So give me 1 second to pull up my presentation. Okay. Can everyone see it? Great. So I really would like to have an ode to public health. Another one of my passions is history. So I like to consider myself to be an amateur historian. And so I really want to focus on the cornerstone that public health has played when it comes to preventing chronic diseases and the lessons we can learn. So, how do we define a chronic disease? A chronic disease has been described as a long lasting condition that persists for 3 or more months and typically progresses over time. Common chronic diseases are to your right: diabetes, heart disease, COPD, asthma, cancer, arthritis, kidney disease, depression, obesity, AIDS. But there are also rare chronic diseases such as autoimmune disease, sickle cell, as well as neurodegenerative conditions, Alzheimer's, dementia. So, I really want to spend this time not giving you a whole lot of demographic data or digits and numbers, but actually allow for you to process the pivotal role that public health has played. And this is data from the Kaiser Family Foundation, looking at the impact of public health for roughly 30 years, from 1990 to 2019, on cardiovascular disease. And for the listeners, it is the number one cause for cause for death in the United States. And so through our efforts, people are eating better. So they're intaking more whole grains, such as oats. I'm sure many of you have seen Cheerio commercials and commercials for oatmeal. We have better monitoring of blood pressure and glucose. So for many individuals who have smart watches or risk monitors, they are able to have real-time data to inform their decision making, whether they need to take medication or change behavioral um, aspects of their health. Additionally, people are trying to lose more weight, and there have been concerted efforts when it comes to tobacco cessation. And overall, this has resulted in a significant decrease in cardiovascular disease. And we would like to see that there's also a decrease in cardiovascular deaths because of these interventions spearheaded by a lot of our public health initiatives. Depending on how old you are, you may be familiar with this individual, and this is Charles Everett Koop. He was our 13th Surgeon General of the United States, and well renowned for his medical acumen. When he became the Surgeon General and in the helm of public health for the US, he played two pivotal roles. First, in really advocating for smoking cessation. We really have to commend him for being the catalyst when it comes to some of the warnings on the cigarette packaging, as well as the numerous commercials that we see that lets us know the long-term effects of smoking. Additionally, I personally feel gratitude because of the work he did to destigmatize HIV. During the late 80s, early 90s, there were a lot of concerns about the transmission. There was a lot of misinformation, mistrust, and he was on the television nearly every night on talking about how HIV is contracted and how we can both mitigate the spread and also understand the delicacy of the issue. And so I truly commend him in his efforts. I don't know how many of you are familiar with this device, but this is one of the earliest models of the refrigerator. And so all public health efforts did not come from stakeholders, but also just from innovation. Um, Most people do not recognize in the United States prior to 1940, one of the leading causes of death were stomach cancer. And it was twofold. It was due to bacteria growth. For our health professionals who are familiar with H. pylori, we know that it is the leading cause of stomach cancer, but also because food spoiled, because there was no refrigeration, people did not wash their hands. So now that you have refrigerators, people made sure that they washed their hands, so that prevented the spread of bacteria. It also decreased the growth of H. pylori. But more importantly, it prevented people from eating food with a lot of preservatives that we know are cancer causing. So, innovations such as refrigeration have played a pivotal role into decreasing chronic disease. And I think, without saying, if anyone recognizes this is an image of a pap smear. So, Dr. Papanicolaou, who was a cytopathologist, and um, I have a deep appreciation for cytopathology, being that I am a cytopathologist. His role in 1920, he came out and said that we are able to do screening for cervical cancer by looking at cervical cells. And I also want to applaud his wife, Mary, because for 21 years, she provided a daily specimen where he actually collected cervical cells from her to be able to look at the changes in the cervix based upon hormonal changes and age. And that helped to bolster this innovative tool that we still use. And so I commend both Dr. Papa Nicolau and his wife Mary for pioneering this. But we know even to this day that that pap smears are play such an important role, particularly in areas where there is low access to care. And so we look at the timeline, even though he brought this to medical attention through publications in the 1920s, it did not become accepted as a screening tool for cervical cancer until 1940s. And then by 1960, that is where we really started to see where it became a true public health tool. The American Cancer Society, we have to give credit where credit is due. They really helped to publicize this and really promote this to women and let them know that they could prevent this. And so between 1950 and 2000, we saw a 70% decrease in cervical cancer rates. And by 1980, we recognized HPV was the initiating factor. And in 2006, um, less than 30 years later, we had the HPV vaccine. So this is just showing how public health can be a catalyst and that there are different individuals and entities and stakeholders that play a role in mitigating chronic disease. Now, if we were to speak to Louisiana in particular, this is not new to us. If we go back more than 200 years to the late 1700s, during the period of enlightenment and the age of reason, we had Louis Philippe Rofenac, who was a state legislator. And he recognized that there were more chronic disease in people who were poor. So he had, the state really invest in infrastructure and economy to try to mitigate the drivers of chronic disease. And one of the key things that he did was plant massive trees throughout the state and throughout New Orleans. And for listeners, they may think that this is inconsequential. But if we were to go back in time into the late 1700s, early 1800s, Louisiana was a swamp. And though he did not understand disease theory and mosquitoes being vectors, they believed in something called putrid inhalation. So, having stagnant water, they believe you breathe this in and then you got certain diseases such as yellow fever and malaria. But despite not knowing anything about mosquitoes being vectors, what he did recognize is that stagnant water being in neighborhoods led to more in people being infected by yellow fever, by malaria, the spread of things such as cholera and dysentery. And so planting trees, therefore, trees would then absorb the excess water. It would prevent the stagnation. Also, being in the deep south in the summer prior to air condition, having the trees created shade. He recognized in the Afro Creole and indigenous populations, they also had lower risk and prevalence of the disease because they actually grew their own food. So they had their own irrigation systems. And so observing the society around him, he really said, how can I prevent diseases? We know street paving prevents animals and people from being hurt. It also allows for water to run off and not just sit. So that was another mechanism to try to prevent disease. He had the city's first fire department. He wanted to educate people. Education is always going to be foundational to preventing chronic disease. Sanitation, public exercise, as well as addressing addiction. And while they refer to alcohol overconsumption and libation as being a disease process, they didn't really call it addiction, but that was part of his efforts as well. So this is actually, I don't want you to take my words for granted. This is actually from the Courrier de Louisiane, and this was the newspaper article from 1822. So I'll just read certain excerpts from it. The mayor of New Orleans invites his fellow citizens to unite their efforts to his, to prevent, if possible, the melancholy effects that result from the inclemency of the season. And he was referring to the summer season. He recommends, in consequence, to the citizens of New Orleans the strict observance and faithful execution of the regulations and ordinances of police concerning the public health and relative as well to the watering of streets at the hours and manner prescribed, and the removing of stagnant waters, unclean animals, matters subject and liable to fermentation and putrefaction, and he hoped that general cooperation will remedy the ills of the summer season and prevent people from dying in droves from yellow fever. So I have a question for you. How did Rofenac learn about public health and disease prevention? So if you scan the QR code, you can share what you believe, how this person during the late 18th century, early 19th century, um, became a catalyst for disease prevention. Okay. Um, so for all of those who voted, well, he did not study medicine, um, and he did not do a Google search. He actually was the nephew of the Duke of Orleans. So, being that he had close relationships to nobility and was considered nobility himself, he recognized that it was the poor individuals that actually um, became more likely to have infection. They lived in close quarters, they were less likely to have proper sanitation, they didn't wash their hands because they didn't have access to fresh water. Also, interesting enough, he also studied Paul Revere. I know most of us think of Paul Revere alerting that the British were coming, but he was also the first public health official in the United States in Boston, and he happened to curtail the cholera epidemic by improving sanitation and paving roads and allowing for people to be able to be spread apart in order to prevent the spread of disease. So I thought that that was an interesting fact. Now, What has changed? If we had all this information available to us and we had a way of addressing chronic disease and preventing the spread and educating people, what changed over the last 200 years that have sort of impacted our health metrics? Well, we went from sanitariums to wellness centers. We went from a preventive model to a prescriptive model, saying that we'll deal with disease after it happens. We went from being producers to being consumers. And unfortunately, chronic disease has become normalized within our society. If I would speak more to sanitariums, so at the end of the 18th century, people who were considered to be infirm, individuals who had TB, chronic diseases, stroke, they were confined to sanitariums, hoping that fresh air would make them better. But they were considered to be convalescent. And so we sort of put them away. But as we learned about the germ theory, right, during this age of reasoning and enlightenment, we started having wellness centers, and wellness centers became hospitals. And unfortunately, everyone did not want to be around different people in society. We had a true caste system. So we had the charity hospitals for the poor. We had Southern Baptists for those who were Protestant. We had Hotel Dieu for the Catholic. We had Turo for Jewish. We had Flint Goodrich for Blacks who had means. We had Sarah Mayo for white women. And we had La Société Française for Francophone speaking individuals. Therefore, we created separate siloed healthcare systems. And for those who were poor, who had to go to Huey P. Long or to charity hospitals, they received lower care, decreased access to care. And we developed a two-tier healthcare system, which further exacerbated conditions in certain populations. And it also led to intergenerational transference of disease due to decreased access to proper care. And if I were to speak to the prescriptive versus preventative model, if we go back into history, we can also see that prescribing medications should not necessarily be the first line of treatment. This is an ad from 1885, and for kids with toothaches, they prescribe cocaine. And I don't need to tell you what the side effects of that is, particularly when it comes to young people, but they quickly realized that that was not the best modality to address chronic pain and conditions in children. And so 20 years later, they reverted back to preventative measures, saying that in the Opelousas Courier, the great importance of giving children their starchy food in a form compelling to adequate mastication was set forth in the British Royal Institute of Public Health. And it went on to say that not only does it cause digestive disturbances, we know that soft food can cause constipation because kids are not eating enough leafy green things that are going to lead to proper motility. It also affects their ability to be able to speak properly because they don't get proper jaw development. It leads to irregular teeth and early decay. And these are things that we still know, and it's proven to this day. So sometimes always trying to address a matter after it occurs is more problematic and can lead to confounding health issues rather than taking a a preventative measure and therefore educating individuals. You would actually prevent these occurrences from happening in mass. And, public health institutions have been speaking to education and really trying to provide different mechanisms that the public can get access to this information, even if they couldn't read. They had individuals going to the community, they had mayors and various health officials speaking to people at courtyards, hoping that they could prevent early demise and the progression of disease. However, times have changed. And this is also a study from the Kaiser Family Foundation from 2018. And this is, how do people feel about chronic illness and the factors that lead to it. And most people feel, 70%, if you look at the first circle on the left, feel that it's due to factors beyond a person's control. However, on the right, people said that it is up to an individual to address these factors. And so there's a fallacy, right? Because we believe that people should pick themselves up by their bootstrap. And so therefore we actually shift the blame from systems and barriers and infrastructure and environmental hazards to saying that it's a person's sheer will that can change their circumstances and address their chronic disease issues. When in reality, I think that it's a balance between the two, and oftentimes the social determinants of health and barriers to access may preclude a person from getting the health access and care and timely treatment that they need in order for them to be able to take autonomy over their health. And so when we look at our diet, we know that diet is a major contributor when it comes to various disease states. It's interesting that looking from 1970 to 2010, our diet has changed, but not in a meaningful way. We sort of had a steady state, a homeostasis, right? So we stopped eating potatoes and moved to eating corn. We went from eating refined cane sugar to eating corn sugars and high fructose sugar. We went from eating beef to eating chicken, from less milk and margarine to more yogurt and cheese. So the reality is that we're eating the same types of food, we just sort of switched it up. Therefore, we really truly aren't seeing the type of impact that we should see when it comes to having better health. And of course, media and propaganda plays a role, but also the fact that we have mass production. We went from being producers of our own food and having limited rations to having mass production and having large portion size of a lot of unhealthy, cheap food, oftentimes with a considerable degree of preservatives. So, what are the structural barriers that we're still dealing with more than 200 years later? Educational inequality. We have infrastructure issues. People don't have access to hospitals, urgent care centers, or food deserts, or food supermarkets, leading to food deserts. There is agricultural exposure issues, public housing. We know that people confined to smaller, close quarters, there is the higher risk of spread of disease. And then there's still the stigma around mental health. And until we address those, we're still going to have errant diet and lifestyle patterns. The people are going to continue to eat what's accessible, what's affordable, what's going to last long periods of time. Because of our tiers of healthcare, there is still a mistrust of systems. And then we have to look at the role of public health. We have been instrumental when it comes to primary prevention, right? I can't drill down enough about the role for health education, but we are really pivotal when it comes to screening, as well as assuring that individuals have um, proper tools in order for them to be able to stay healthy. We are also a part of that secondary prevention, early diagnosis. It's important that we measure blood pressure. I think we can go into any pharmacy and see that there is a free blood pressure cuff so that a person can check their blood pressure, talk to the pharmacist about it. We make sure that we do it at our FQHCs and public health units. And so we really try to have early diagnoses. We put up signage, letting people know if they have any type of symptom that they can speak to us about this in order to try to get ahead of something before it comes to fruition. And I think we're really trying to tackle that head on when it comes to obesity, recognizing that it is associated with a myriad of conditions, sleep apnea, cardiovascular disease, whether people have issues when it comes to neuropathy and it can potentially lead to amputation. We really try to say, how can we be upstreamist in our approach? And that is the role that public health plays. In addition, reducing complications and disability, um, having that relationship with the public, recognizing that some will not have close proximity to tertiary care center, or they may not necessarily have insurance, helping to fill the gap, address the chasm will actually help to promulgate better policies, but also alleviate some of the healthcare costs associated with taking care of individuals with chronic disease, as well as making sure that they're able to be functional members of society to be able to support themselves and their family members. And that's why we talk about the autonomy of the person. Historically, medicine, even from a public health lens, was very paternalistic. But now we actually talk to people and say, how do you want to receive this information? How do you want the government? How do you want healthcare practitioners to assist you with addressing chronic disease and promoting better health? They say education. They want education in schools. They want kids to have better food choices. They want them to promote exercise so they don't become sedentary and just want to game or stay inside all day. They want to increase funding to promote healthy choices through media ads, require restaurants to show the caloric intake so then people can make informed decisions whether they're going to have that unhealthy savory dish, and maybe they may limit their portion size and say, I'm going to eat half now and save half for later, or whether they may choose to have a healthier item. In addition, it's interesting what people don't want. And so they don't want to have their options policed. They don't want to be restricted on what they can consume because they feel that they are smart enough to be able to make the appropriate decision for them and their household. However, they recognize that people may be penalized if we were to tax them at a higher rate. So while they may not be a proponent for sugary foods or for smoking, they feel that higher tax is regressive. And those who are more prone to um, use these as methods to deal with stress are also those who may be more likely to be impoverished. So, paying $20 for a pack of cigarettes for a billionaire would not have the same impact of paying $20 for a pack of cigarettes for someone who's impoverished. And it actually does not uh, stymie them from pursuing this because we recognize that certain things, including food and sugar, can be addictive, and they will forego maybe other critical needs, maybe even healthy diet. So it's interesting that the public recognizes that there are things that they want public health and governmental entities to do, but there are also things that they feel would cause greater harm than good. So, what is the role, and what is the role that Louisiana has played? I would say that within Medicaid, we have expanded smoking cessation programs. Uh, Initially, we piloted tobacco cessation um, for pregnant women, and then we expanded it for all Medicaid recipients. Diabetes prevention initiatives, we've had pilots with pregnant women trying to prevent gestational diabetes, doing remote patient monitoring, recognizing that having real-time data and being able to speak to patients outside of office visits, having telehealth allows for better monitoring and hopefully better outcomes. Community-based interventions. I believe that we're all proponents when it comes to community health workers and having individuals who are trusted resources in the community at the avail um, to the public. And I can't underscore the importance of having individuals that are from the community, embedded in the community, teaching and providing resources to individuals. And Louisiana, I think we did a good job of trying to mitigate COVID during the height of the pandemic, using various resources, the Department of Health, the Department of Education, recognizing that those who had chronic conditions oftentimes had a worse course and had more morbidity and mortality. So, being able to connect the dots and say, what are we doing well and where there's potential for us to improve, um, has been imperative as we continue to improve our policies and advocacy. So, Medicaid expansion allows for us to get people in early so they're not just interfacing with us at the emergency department or urgent care with conditions that are far long and may be hard to remedy. So, getting people in and really emphasizing preventive medicine uh, has been instrumental, and we're hoping to see the fruits of that labor. There's been a lot of legislative advocacy for cancer care, for ensuring that individuals have access to care during emergency response, school based programs. People will take their kids to school. So, sometime having convenient clinics on the school that allow for faculty, uh, students, as well as parents to be able to access a full clinic prevents them from having to miss work, prevents them from delaying an office visit that they may think is inconsequential, but can actually add years to their life or prevent them from having a truncated, productive life. And obviously, our SHIP program. Um, so, having the SHIP plan, the State Health Improvement Plan, provides a directive not only to our staff internally, but it lets stakeholders know what our priorities are so we can work on them in concert, right? So when we do things in concert, we hope to have a synergistic effect. But being from Louisiana, for individuals who come here and love our culture, it's hard to redefine culture. And so I just want to lead with this, that sometimes the things that we do them because they've been passed down from generation to generation. But if we actually understood why it was passed down, we would change our ways. This is an article from the New Orleans Times in 1877, when we had a huge influx of immigrants to the South. After slavery, they came for opportunity, they came to take over certain jobs and skill sets. And so I'm going to read just snippets from this. Pass these butcher pins at any hour, and the impression is a bloody one. Blood issues in little pools from beneath the walls, forms little pools on the sidewalk, drips and coagulates in the gutter. Blood and manure heaps gather and grow maggoty beneath the floor. Water is seldom used, as water must be used for family purposes. This is the impression of all those who see this trade waddling about in their bloody dens, on floors slippery with blood, driving blood carts, sweeping out refuge into the backyards. Now it is the general impression that these neighborhoods are healthy. And so they are to the good people who live there, who are born here, whose nostrils draw in the tainted atmosphere from the time they are born until the time they die. And then it ends by saying, in fact, at slaughter time, one may see crowds of children, bare-legged boys and girls, swarming around the pens to pick and buy up livers, gallbladders, and other parts of the slaughtered animals. These are in due time worked up. The best of the manufacture appears in these markets to become tripe, which is very common in Latin populations. Hoghead cheese, very common in Creole and Acadian population. Sausage, boudin. And so, why do we eat the things that are left over? Refuge. This was a diet of poverty that led to disease, and people didn't realize how unhealthy they were, and they pass it on from generation to generation. So, what do I want you to take from this? Public health has been integral, foundational, and is proof of concept that it works. However, we can't let go and think that these methods are trite. They are actually critical to our future endeavors. So we have to integrate this into preventative medicine into every parish. We have to educate people. We have to meet them where they are. We have to expand access to telehealth and mobile clinics, but we have to use the things that we have. We have to use the information. So, BRFSS data and LAHI data, we have to use this information to actually guide how do we communicate with people. We have to empower community health workers with information, letting them know that they are truly the beacons. Of our public health workforce, of LDH, in order for them to be able to penetrate into people and their behavior, understanding their needs, and they're not embarrassed and they're able to come forward, recognizing that we truly are on their side and we want what's in the best interest of our total community, not only certain segments. And the only way to do this is if we go back to where we started from, tackling the social determinants of health. That's what we did in 1799. That's what we were doing in the early 1900s. And that's what we should be doing now. So thank you.
Thank you, Dr. Aber McGee, for such an inspiring and informative presentation. Wow, I really enjoyed this. So at this time, we will have our Q&A segment. As a reminder, for all medical questions and or advice, please consult your physician. But for now, feel free to drop your questions in the Q&A box and you will be acknowledged by one of our team members. So I see a few things in here. I'll go ahead and call them out. So we've got one comment that Paul Revere's youngest son was founding faculty of New York University School of Medicine in 1841, NYU Medical Center and Bellevue, and in quotes, John Revere Medical Society. And so thank you for
Awesome.
that comment. That's great. Okay, another question. How do we really convince citizens to take advantage of these resources?
The thing about it is that because we have a prescriptive mentality, right? We always go after the fact. You say, I ain't worrying about that. Oh, I'll get on a diet. I ain't worrying about that. I'll just change this. Um, well, I can go to the doctor for that. They're gonna give me something for that. So we put off things because we haven't seen the consequences of those actions. Then we've normalized it, right? We say, well, oh, diabetes run in my family. I mean, if I get sugar, I just get it. I'm gonna just take my insulin and so forth, versus saying, how can I prevent it if possible? We know that certain things do have a genetic component, but also is due to behavior. Um, I think because we blame people, because we say, you have to do this and you have to do that, there's a certain shame. So, why would I want to engage with the healthcare system if they're going to turn back to me and say, you should be doing better? You need to exercise more. Well, if I'm a single parent taking care of a household full of children, I have two jobs, I can barely sleep. When am I supposed to exercise? Or they say you can do a better job um, of eating or not smoking. In society, we particularly, we have an oral gratification fixation, right? When a child cries, what do? We put something in their mouth. We give them a breast, we give them a nipple, we give them some candy. And so we grow up thinking that putting something in our mouth is pacification. I mean, it's almost like a Pavlov's effect. So if I get frustrated, where are those Lay's potato chips? Or where's happy hour after work? Or where are my pack of smokes? So I think we have to get to the root cause issue. And the way you do that is actually getting to know a person. It's not just passing out flyers at a health fair. It's not just saying these are our hours. It's actually saying, hey, what brought you here today? I came to get my child a school bag. You know what? I commend you for being a parent and finding resources. Do you know we also have other resources? Why don't you come by and just talk to us? I would not even promoting different things, just come by and talk to us. I think there's more that we can do for you. Now, they may be thinking that we're going to give them some money, or they may be thinking that we're going to give them a card. But if we give them a new lease on life, do you know how many people we've saved from having advanced cervical cancer? I mean, people think that, oh, they can do a little copo and I'll be okay. There are a number of women who are in their early 30s who are dying stage 4 with cervical cancer that could have been prevented. And I believe that there was a write up in OPH, I believe recognizing region 1 for diagnosing an early cervical cancer. And that woman went to copo, and it gave her a new lease on life and allowed for her to continue to be a mother and a contributing member of society. And, you know, getting your kids out of poverty, being present. We know that it only takes one wrong turn to have a rippling effect in community. So how do we change the tide? Get to know people, invest in people, not in the diagnoses, not in providing information alone, but actually talking to the person so you build that trusting relationship. So then they come to you as a confidant and they don't feel shamed about whatever diagnoses that they have or may come about. And they feel that you care about them like their own parent or a favorite teacher or whomever is instrumental in their life. That's how we do it. One person at a time, just taking one bite at the elephant, one at a time.
Mhm. That's a wonderful answer. Thank you. And that's a great question, too. We've got another question. With all of the work we have done within the Bureau of Chronic Disease Prevention and Healthcare Access alone, how and when can we see data that shows we are improving healthcare outcomes in Louisiana?
So I think the issue, right, and what I tried to speak to in the presentation is that it's not just access to a care facility, is not just um, having expansion of Medicaid. Until we deal with the root causes, until we address poverty, until we address educational attainment, until we address job opportunity, people are going to wallow in some of these conditions. So we can ply them with medication. We can get, increases in our workforces. I think those things help bite at the apple, but none of those things are a panacea. You have to have all the coordinated efforts as well as opportunity, right? If I can have a freshly curated salad every day, if someone could drop that off, then it's highly unlikely that I'm gonna stop and order a pizza. Not that I'm gonna completely say I'm never gonna eat pizza again, but instead of me getting that two medium-sized pizzas for $10 and eating slice after slice until it's gone over 2 days, I mean, that has very low nutritional value, and that is going to affect my cholesterol and all other types of things. If someone, if I lived the lifestyle of the rich and famous, I mean, yeah, I'll wear a size 0. I'll have a coach, someone who is getting me on the treadmill, get me that Peloton. I mean, I'll have all those things. And so then we will see the metrics that you see in Massachusetts, in California, in New York, in Vermont, in Hawaii, because those states are richer states. Those states have better education systems. Those states have better opportunity. And so until we take a holistic approach, it's going to take a while to see the changes that we are so invested in. I don't know if that's a good answer or bad answer, but I think it's my truthful answer.
I think that's great. Thank you for that. And we've got another question. If we want to expand telehealth, is there any work being done to build a stronger broadband infrastructure for rural communities?
I think that was, and I don't want to say was, I think it is a priority of our legislators. I know that there were a lot of initiatives, and I believe that we've already started to make inroads. I believe there was some funding in rural Louisiana to build that infrastructure out. Of course, we know that Rome wasn't built overnight, so it's going to take some time. But I believe there was committed dollars. I believe that we started to break ground on that initiative, recognizing that yes, while telehealth is great, akin to a lot of innovations, we know that they can be disruptive. And typically, when disruptive innovation happens, there are still laggards. There are people who are left behind. There are still people who have those flip phones. So even though they have a cell phone, they can't really interface with you through video. Or even if you get the broadband up, guess what? They don't have the minutes. They don't have the data plan. And they're not going to use their data trying to answer your questions about, how are they sleeping? Have they had a headache? Do they have blurred vision? No, they're trying to keep their data so they can go on social media or find them a job or communicate with their family, things that they feel are priority. Because while we may say social media is should not be a priority, for some people it's a stress relief. It's that, they can't go and get a massage, they can't go on a golf course, but if they get some words of affirmation, if they know there's somebody else going through the same trials they're going through and they still smiling. So we have to realize that what we think someone's priority should be may not necessarily be their priority, and that's reaching them where they are, stepping into their shoes, not judging them based upon the clinical information we're looking at. And that's building that relationship. So, relationship, investment into community, I cannot underscore how important that is to public health, to getting well ahead of the problem, hint, hint, but also to, to really just tackling all these issues. So I commend all the bureaus and the work that they're doing. I think we're on the right track, but we really have to have all hands on deck in order to get us out of this pit that we're in.
Wonderful. That's a great answer. We've got time for one more question that came in. How are we increasing community health workers in rural communities? Oshner has an apprentice program. Are we doing any partnerships with other organizations outside of LDH?
So I know that LSU Health Sciences Center has a community health workers forum. And the issue is that the way our current policy reads is that community health workers, in order to be reimbursed, they have to be under the direction of a healthcare practitioner, meaning that there has to be a physician, a nurse practitioner who is actually supervising them in order for them to be reimbursed by Medicaid dollars. Now, there are various CBOs, community based organizations, that have community health workers and they have grants. The issue is typically that grants are not sustainable, right? So they can be there for a year or two, maybe 5 years, 7 years. But how do we have a sustainable mechanism? Because once you bring something to people and they rely on it and they see that person or that entity as a pillar of the community and they go away, they once again feel like, why did I even invest in these fledgling institutions and wishy-washy programs when, they're going to be gone, a few years from now or a few days from now. So I think there are entities, stakeholders who say, hey, maybe I can fill that gap. I can work with that community based organization. We have physicians on deck. Our physicians can supervise and then they can get reimbursed. But once again, I think it takes capital for them to work with those companies. And I believe that some of them are piloting these programs, trying to see if it is viable. Can it be a win-win for the company that has the supervisory staff, as well as a community-based organization, which is not able to afford to have a healthcare provider so they can get these Medicaid dollars? I think because we recognize that there are some barriers, I would hope that at the state and federal level, we will continue to explore this. But we do have a number of initiatives that are happening in tandem so we can observe, get information, and determine what works.
That's wonderful. It's a great answer. Thank you, everyone, for your questions. Those were wonderful. I will turn it back to Dr. Glennis Gray for a few closing remarks.
Thank you, Anne Marie. I just want to take the time to thank everyone, especially Dr. Chantel McGee. We hope that you're leaving with some valuable insights and some practical tools that can enhance your well-being. She gave you a good background on public health, And so remember that wellness is a journey. It just doesn't, start one day and stop. And it's a full length journey. You have to do small, consistent steps in order to lead to meaningful change. So if you can stay mindful, prioritize your self care, because if you're not well, of course, you can't take care of anyone else, and support each other in your wellness journey. I think we're going to get there. If you have any further questions as we move forward in the year, please feel free to reach out to the Well Ahead Department or Anne Marie. I hope that you stay well, stay cool because it's hot today. Stay inspired, and we look forward to seeing you at future sessions. Thanks again for joining us. Back to you, Anne Marie.
Dr. Grant,
Thank
you
you,
should have
Dr.
told them to plant a
Green.
tree.
Ma'am?
I said you should have told them to plant a tree to stay cool.
Right, exactly.
I love that. That was so great too. I'm inspired to do that as well. So thanks everyone for joining us. And a huge thank you to our keynote speaker, Dr. Chantel Hebert-McGee. We are walking away today more enlightened, educated, and empowered. So to find out more about Well Ahead and our numerous programs and services, please visit www.wellaheadla.com or contact us at wellahead@la.gov, or you can call 1-844-522-4323. Thanks for joining us today. Goodbye, everyone.